Can I have the slides? Okay, thank you. That you know that juxta renal occlusion are very difficult to treat because we have many challenges related to the patient condition in general. When we have occlusion, we have patient with severe symptoms. We have anatomical complexity in case of calcifications of the aorta with the risk of rupture. We have long occlusion with common femoral artery involvement in some cases, and we have the risks related to the intervention with the risk of acute or late renal occlusion. And also we have the reconstruction issues that we can see that it was already discussed. We have the configuration like kissing stent, and we'll go fast for that with good some results, but the patency affected by the flow turbulence and the metallic stance in the crash zone. The syrup technique could be more physiological for the flow and with less turbulence, with maybe better control of the plaque by using covered stent, which will be limit the restenosis to the edges of the stent and not in all the stents. But we have the problem with the aortic stents is the diameter and the need to use a large aortic diameter and large sheath using 9, 11, or 14 flange with a risk of access complications. So, syrup, as was shown, have good results. Hani Zayed published this paper with 83% freedom from TLR, confirmed by this another paper with 160 patients. Another way to go for proposed by Professor Koskas is when we arrive to recanalize one side and difficult to go intraluminary from the other side. It's possible to put a stent graft in the aorta in case of occlusion of the aorta, of course, and then to make in situ fenestration to go intraluminary via the endograft. Compared to the aortobifemoral bypass, we can see that we have an increasing of syrup techniques and decreasing of the aortobifemolar, but even if results at 1 year showed the same primary patency, aortic bypass is still better in terms of major adverse limb events. So in case of a flash occlusion, we have a risk of acute and late renal occlusion. So the key of success is the management of the proximity of the renal arteries by protection. The protection of the renal arteries, it could be made by a balloon, like in this case that we can see the flash occlusion, and then we protect the renal arteries with the balloon at the level at the time of implementing the stent graft. We also could make a chimney technique with syrup, like in this heavy calcified lesion of the aorta. We performed one chimney stent in the renal artery with a aortic stent graft in the juxtarenal aorta. And the chimney techniques could also be performed with EVAR, like for EVAR. Here, thanks for IVL, it's now with the IVL we can make some aortic occlusion, very calcified lesion with the EVAR or with endograft or auto-expandable stents. But for when we have to do chimney, we have to think about the upper axis with if we have one target artery, we can use a long sheet from the brachial, but if it is more than two, we have to go to the axillary axis. In some cases, we have acute occlusion in chronic lesions, and the La Sirap technique was described. It's lysis before the Sirap technique to to gain in flow and which will help after to recanalize the aorta and to have better results on Sirap. We have some cases described 9 or 10 in this paper, but it seems to have good results in case of acute on chronic lesions. And of course, in case of heavy calcified lesions, we have actually the IVL shockwave L6, which will help to fracture the calcium and give more compliance in the vessel. And of course, this type of patients, we can use auto-expandable stents or balloon expandables because we have a good expansion of the stents after IVL. Here, a case published by Truazi using two IVL M5 plus in the aorta to prepare a heavy calcified aorta. Other cases were described by Stavroulakis. We can make a kissing with a catheter IVL in one side and a balloon in the other side to avoid using two IVL, which is very expensive. My question for me is the problem is how to approach aortic reconstruction. Would we have to focus in the diameter and to have to respect the anatomical diameter and to open the aorta to the real diameter with taking into account the risk of aortic rupture and the access complication. We know it is a occlusive disease, so the access are not easy to put 11 or 14 French. Or we can discuss and think for a bifurcation as for the coronary bifurcations or peripheral artery disease, something that we published for the common femoral artery bifurcation, and to not focus on the anatomy, but more in the flow, and to use the Murray fractal formula that will calculate the diameter needed to have the best flow of the mother vessel, uh, taking into account the diameter of daughter's vessels. And when we applied this formula to a 8 millimeter iliac diameters, and we asked to the Murray formula to give us the best diameter of the aorta to have a good flow, we will calculate 10 millimeter of the aorta is enough to have a good flow in the iliac in two iliac arteries of 8 millimeters. So let me show you a quick case of 76 years old man, Rutherford 6. And in the patient, as we can see in the CT scan, we have flush occlusion with calcified, very calcified aorta in the bifurcation and in the iliac axis. And we can see that the lesion is going down to the common femoral artery, and the axes are really ugly. So in this case, I prefer to go with a bifemoral axis and a non-triggerate axis, which will allow me to recanalize both iliac arteries. And as we can see here, is there's a preoperative angiography, and we performed a CRAP technique, but using just a 7 French sheet with 10 millimeter stent eye cover, dilated with a Atlas Gold 14 millimeter and 2 eye cover, a kissing stent for the iliac arteries, and finally a Viaban in the external iliac artery. And here we have the post-operative clinical results, and with the follow-up, we can see that we have a good patency for the stent graft, and we do not have total expansion of the stent in the aorta, but in the real life, did we really need to respect this diameter, or putting a 12 millimeter diameter is enough? So, in conclusion, ladies and gentlemen, I think the endovascular treatment maybe will become the gold standard of the aortoiliac occlusion for a flush occlusion. CRAP technique provides good results because of the physiological endovascular reconstructions. Lysis before CRAP, when we have acute on chronic occlusion, is important, and renal protection is the key of success in this lesion. And finally, the open question is: would we really to respect the true aortic diameter, or we can choose to treat the flow and not the diameter? Thank you for your attention.
Thank you, Dr. Bahaa. Have a seat, please. We can call for the last session Dr. Ala Ahmed. He will talk about crossing complex chronic clotted occlusion in aortic occlusive disease, new device, new technique, better outcomes.
بسم الله الرحمن الرحيم. Thank you, Dr. Mahmoud Salah, for the kind invitation.